so that we'll take them one by one. So I'm not going to waste any more time. We're going to delve right in. Just to introduce the speaker for today. She's an accomplished mental health professional with a passion for child and adolescent mental health. She is a specialist psychiatrist and a senior resident in child and adolescent psychiatry at Kolibu Teaching Hospital. She equally has extensive experience working with children, adolescents, and family, and of course, navigating various mental health challenges. Her expertise, we believe, makes her well positioned to guide us through today's topic and help us better understand the place of medication within a holistic treatment approach. Please, you can kindly help me to welcome Dr. Abigail Harding as she takes us through the topic beyond the prescription. Of course, the role of medication in child and adolescent mental health. Doc, please, good evening, and you have the floor.
Good evening. Thank you so much for the introduction. I hope I'm audible. I may turn off my video so as to reduce the bandwidth if the internet connection becomes unstable. But do let me know if I'm audible. Hello?
Yes, please, loud and clear. Thank you.
Okay. Okay. Thank you very much once again for having me. And as Sanita mentioned, we'll be looking at the role of medications in child and adolescent mental health, and we'll be looking beyond the prescription, so beyond what we usually see at the front lines, what goes on behind prescribing in child and adolescent mental health. Okay, so I hope by the end of this presentation, we'll just touch briefly on some of the statistics about child and adolescent mental health, just to give us some context about where we are situated with the discussion we are having. And then we'll describe some of the evidence base for some common psychiatric medications that are used in children and adolescents. We'll also look at some of the myths and truths about medication prescribing in adolescent mental health, discuss some of the risks and benefits, and making decisions as to whether to proceed with medications in this population, recognize the role of psychotherapy, the family, and other interventions as complements to medication, and then how we can communicate effectively with other stakeholders about treatment options, and look at some key safety monitoring principles that are required and essential when we prescribe medications in this population. So as to the scale of the problem, we know that worldwide, the World Health Organization estimates that 1 in 7 children and children and adolescents, that is aged between the age of 10 to 19, lives with a mental health disorder. And the most common in this group is depression, anxiety, ADHD, and conduct disorder, as well as autism spectrum disorder. So these conditions contribute a major portion of this burden of people, of children and adolescents who have mental disorders. But what is really striking is that about 50%, that is just half, 50% of all lifetime mental health conditions begin by age 14. So if you see someone at age 30, 40, 50, 21, it's likely that at least in 50% of the cases that this problem started by age 14. So that should let us know that a lot of the times we are missing people when they come to see us with mental health disorders. And unfortunately, in where we are situated, a lot of people have no access to treatment. The situation in Ghana is not so different. I found that about 12 to 29% of children and adolescents in the African continent have a mental disorder. Sorry, that's in Ghana. So the studies range from about 12 to 29%. So we are still pretty high up there, suggesting that our children and adolescents are experiencing some of these conditions that I mentioned. And we know that things like stigma, cultural barriers, and lack of child psychiatrists remain challenges to people accessing treatment in this population group. So let's dive into some of the myths before we even get into the nitty gritty about medication prescribing in this population. I want us to dispel some myths right off the bat. And some of the most common things that we hear are that children can't have real mental illnesses. They are just going through a phase, or they'll grow out of it. I'm just waiting to see. Things will get better. Though that's how I was when I was a child. I know people who were like that. So the same thing is happening in our family. I recently heard in our family, the children are all like that at that age, so they'll get out of it. The truth is that mental disorders in children are real. They are real conditions that have biological, sometimes psychological, and sometimes social causes. So they are not phases. It's not a stain on your parenting style or a weakness of character in either the parent or how the child was raised. Sometimes it truly is a biological problem. Sometimes things they've been exposed to, yes, can contribute to the presentation of a mental disorder, but they are not generally not phases, at least real mental disorders in children and adolescents. They are also not caused by witchcraft, a spiritual attack, or a family case. I'm sure this one cuts across not just in child and adolescent psychiatry, but in other areas as well, because we tend to always ascribe um, witchcraft and spiritual meaning to mental disorders. But we know that they result from a complex interaction of genetics, brain development, adverse life events, trauma, the environment within which the child was raised. And they occur across all cultures, religions, social class. So it's not you sitting here in Accra or Kumasi or Boise that someone is targeting you. So that person targeting you, they're also targeting millions of other children all around the world. Um, there's also a general, and sometimes some parents also have some beliefs that psychiatric medications will make their child permanently dependent on the medication, will make them like a zombie, will make them an addict dependent on it, and they can never stop taking the medication. However, we know that when the medications are properly prescribed and monitored, they do improve the quality of life. Addiction to medication, at least those that are therapeutic, is very rare when we prescribe them properly. And these some of the side effects, yes, we do agree that some of them do have side effects, but some of them are largely manageable. They are reversible, and they also resolve spontaneously. Sometimes some people also believe that if we just discipline the child more strictly, the behavior will stop, especially in conditions like attention deficit hyperactivity disorder and conduct disorder, sometimes autism spectrum disorder. Some people believe that you need to be more firm or more harsh or discipline them more so that that challenging behavior will stop. However, sometimes harsh discipline can worsen the outcomes, especially because the condition has a biological basis. You cannot out discipline or beat it out of a child, something that is part of their genetic makeup or their neuro certain chemicals responsible for that. And so sometimes we know that structured compassionate approaches are more effective. And then the big one that we sometimes hear is that children don't experience real depression or anxiety. What do they have to be depressed about? You are a child, everything is provided for you. You have a roof over your head, you have food, you don't have fees to pay. I do everything for you. Why should you be experiencing depression or anxiety? But we need to look at it from the child or adolescent's point of view. There are certain things going on in their lives that you may not be experiencing, and so they are also just also have their rights to experience some of these conditions. And we know that early identification and treatment can prevent chronicity and long-term morbidity or more or complications down the line. So where do medications fit in the child's life or in care for a child with a mental disorder? And you would see from this diagram that medication or pharmacotherapy is just one arm or one aspect of the care of a child with mental disorder. There are other interventions that need to be put in place, like psychotherapy, school and social interventions, and then the family and the caregiver also play a critical role. So medications are just a tool in the whole box of tools that we have to manage a child with a mental disorder. And we'll find out that it actually works better when we combine these therapies so that we can get the most it can be most effective for the child. So let's look at some of the disorders in particular. The first ones we'll look at are anxiety disorder and depression. So for anxiety disorders, we know that these are disorders where the child or the adolescent has persistent anxiety that cuts across all aspects of their lives, and it impairs their ability to do things that are required of them. So attending school, being in relationships with their peers, with their family. So those are all that's when we've reached the level of a disorder or an anxiety disorder. And in anxiety disorders, usually the first line of treatment is psychotherapy in children and adolescents. So there are different forms of psychotherapy. I'll not go through them, but you'd also find down just in the next box is medications, which we call SSRIs. And there are a number of them. Fortunately, there are about 3 of them that are approved for use in children and adolescents. And so they've been found to be safe in children and adolescents. And sometimes they can be first line because sometimes the anxiety can be so severe that the child needs some medication to be able to manage some of the symptoms before they are even receptive to psychotherapy. Sometimes psychotherapy will be first, and then medications come second. Sometimes it has to be the other way around, where medications come first and then psychotherapy will be second. But in the last box, you'll find that a trial done in some children and adolescents, about 500 of them, showed that the combination of psychotherapy plus medication was actually superior to each of them on their own, so a standalone. So doing psychotherapy on its own, doing SSRIs on its own was not as effective as when you combine the two. So they work in science, we call it synergy. They work synergistically. They are working together to produce maximum efficiency or effects. And then in depression, where there's persistent sadness or persistent low mood, low energy with associated symptoms. Again, the person is not able to do their basic functions, self-care, be it attend school, look after their own hygiene. In children, it can be less classical presentation. So some children may not present with sadness, explicit sadness, but maybe angry all the time, have outbursts. This is not the way you knew the child you and so we find changes in their behavior, their personality, a decline in academic performance. These are things that can point to a child having some challenges with their mental health. And so sometimes when it's caught early, it can be mild. And in that case, we can do start off with psychotherapy and monitor, because unfortunately mild can progress to moderate and to severe. So this is a point where we would address other aspects of the adolescent or the child's life. So we'll look at things like their sleep, their exercise, their diet, other interpersonal relationships they are having, school issues they may be having, to try and see if we can mitigate some of the things that may be contributing to the disorder that they are having. And so we call it watchful waiting. But when we say watchful waiting, it's not that we are waiting and doing nothing. We are watchfully wait. So we are monitoring, we are assessing, reassessing, putting in necessary interventions, and then also doing psychotherapy at the same time. When it's moderate to severe, usually that's the stage at which a lot of people come to the clinic, unfortunately, because they wait so long, and we see them at the point where the depression may have become severe. Then in that case, we do need to start antidepressants or the SSRIs. And fortunately, fluoxetine has been approved for use in children and is the safest in children. Like I said, again, combination with psychotherapy is always better than each one on its own. However, you need to remember that at all points, anytime we prescribe medication for a child, we always want to do close monitoring, because antidepressants can have some side effects that we'll touch on briefly in the next few slides. But usually in the first 4 weeks are the time periods, at least for most medications, when you need to be mindful of the side effects. And so we always want to monitor, reassess, check what's going on with the adolescent to make sure that they are not experiencing any of those side effects. And if they are, then we put in interventions to try to mitigate them or reduce them. So the next disorder we'll look at is pharmacotherapy. Is attention deficit hyperactivity disorder. And in this disorder, we have quite a number of medications available to us that can be used. And attention deficit hyperactivity disorder is a disorder that is characterized by inattention, poor attention, and hyperactivity. So you can have two arms where you are predominantly inattentive, where you struggle to focus tasks that you need focus on. So doing homework, writing, following a lecture in school. And then where sometimes the child is predominantly hyperactive, where they move about all the time. They are not able to sit still. They are not able to wait their turn. So some children may have a combination of these symptoms, the inattention and the hyperactivity. It's a disorder that we know is more common in boys, but it's usually seen somewhere from the ages of 5, 6, 7, usually when children start class 1 or year 1, and then we tend to see some of these things. Fortunately, there's medication available, and in ADHD, we always like to manage not just with medication, but with other interventions, because Medication, we know, has its own side effects again, and um, the child will not always be on medication. So we need to put in interventions that can outlast the period within which the child will be on medication. So again, we always want to assess the child medically, assess them for any side effects that they may experience, because some of the common things are appetite suppression, where they have reduced appetites, they are not able to sleep, they may have headaches. And so we need to make sure that these things are not happening. We also monitor their weight, height, BP, heart rate, and all of that, just to make sure that we are keeping an eye on all the things that could affect the child with the medication. However, like this chart says, medication does not replace psychoeducation and school support. So school supports are one of the large things that can be done to help a child with ADHD. And so things like peer support, facilitators, explaining to the teachers, trying to structure schoolwork and classwork. There are all sorts of interventions that can be put in place for a child with ADHD. And the medications you see on the left, usually we start off with stimulant medications, and those are usually the first line. But there are also some non-stimulant medications that can be put in place for children who don't respond too well or have too many adverse effects from the stimulant medication. So there are always options. Sometimes I find that when a child does not respond well to one medication, parents give up and say, that's the end. Nothing can be done. But there are other options that are available for the child. And then another group of disorders. In this group, we have schizophrenia, which is a psychotic disorder where the individual loses touch with reality, and so they are not able to make meaning of their environment. And so they may have some unusual behaviors, say some unusual things. And in that case, we say they have psychosis. And so with psychosis, it's a condition that requires medication. And so it's not something that you watchfully wait. And sometimes some children can have what we call early onset psychosis. It may start at the age of 14, even as young as we've had patients as young as 11, 12. That happens especially when there's a strong genetic risk or there's a family history. Sometimes even there may be no family history, but some children can present very early with psychosis. And again, there are medications available. Fortunately, there are newer antipsychotics. Those are the medications used to manage psychosis. And there are quite a number of them that are good and approved, safe for use in children. The main risk with this group of medications is weight gain. And so it can increase the child's weight. It usually does that through increase in appetite. So it boosts their appetite, and so they eat more than usual, and then in that way they also gain weight. But again, we always monitor. It's the reason why when you take medication, you are prescribed medication, that's not the end of it. There's always monitoring after the medication is given because of these reasons. It's a risk benefit assessment we do. There's a lot of risk that comes with not taking the medication, and then there's also risk that comes with taking the medication. So because the individual needs the medication to function, to be able to go on with their lives, we monitor to try to reduce some of those side effects and those risks that come with taking medication. And then with autism spectrum disorder, there is no medication. This is the condition where in child and adolescent mental health, where there's no medication that treats any of the symptoms within autism spectrum disorder. So those are the core features of autism spectrum disorder. And for those of you who don't know, autism spectrum disorder is a disorder that's characterized by social communication deficit. So when we say social communication deficit, we mean the child is not able to interact socially with other people. They have restricted interest. They have some repetitive movements. And so these are children we say are neurodivergent. And when that happens, there's no, we need to modify the way we interact with them, and also be able to teach them how to interact with the world. And in that situation, there's no medication to treat that. And what can be done, medication that can be given, is when the child has aggressive episodes where they injure themselves, or there's some irritability. But that's when they get angry easily. There are some medications that can be prescribed. But again, these are short-term medications that we prescribe only to give us some time to be able to manage the underlying problem, or the underlying cause of the aggressive behavior or the problem behavior. Sometimes there are some other problems that children with ASD can have, and they can also benefit from medications, especially when they have ADHD or sleep problems. But the mainstay of treatment for autism spectrum disorder is therapy. So different forms of therapy, but applied behavior analysis, speech therapy, occupational therapy, those remain the primary interventions for ASD. Bipolar disorder is also another severe mental disorder that can present in children. There are also medications that are readily available for children and adolescents. And in these bipolar and schizophrenia, they are the disorders that be characterized as severe mental disorder, and so require medications to be able for the child to be able to function and to mitigate some of the symptoms they're having. In all these situations, anytime we prescribe medication, again, we always monitoring. It's what should be done after the medication is prescribed. And so parents, caregivers, please don't run away. Don't go and take the medication and come back in 1 year and say, I've been taking medication for the past 1 year. I didn't come, but I was still taking the medication. I didn't come for follow-ups, but I was still taking the medication. Because we do monitoring to make sure that there are no adverse effects on the child, especially a developing child, a growing child, an adolescent child. You want to make sure that they are not experiencing any adverse effects. And also remember that sometimes, even when we prescribe, we may reduce doses based on what the child is experiencing, some of the adverse effects. If they're experiencing side effects, that's not the end of the world. We can always reduce doses to the point where the child or the individual is able to tolerate it. And so there's always wiggle room when we prescribe medication. So this is the risk benefits framework. Like I said, yes, there are risks when we prescribe medication. In the short term, you can have adverse effects or side effects. You also have to think about the costs and how accessible the medication is. In adolescent females, there are some medications that can be harmful to a developing baby. So since adolescent females are at risk of becoming pregnant, is something we need to think about in that age group or in that population. But there's also the risk of not treating. When we don't treat individuals or children and adolescents, it means that we are increasing the risk of chronicity. That is pushing them to have an adult psychiatric disorder, pushing them into substance use, and reducing their life expectancy. There are studies that have shown that children with ADHD who don't receive treatment have a higher risk of substance misuse in adulthood. So these are some of the things we need to consider. But even though there are risks, there are still benefits. So symptom reduction is the biggest one, functional improvements, because once we reduce symptoms, the child can go to school, can do what they need to do, complete university, have relationships, talk to their peers, compete in sports, activities, competitions, do essentially live life and be children, be who they are supposed to be. Can also prevent long-term complications and problems that may arise if we don't treat the individual. Like I mentioned earlier, sometimes medications can enable access to therapy. So when some disorders are very severe in the child, they may be not receptive to therapy. And so we sometimes need to institute medications first to allow the child to be less anxious, more receptive to some of the psychotherapeutic interventions. It also improves the quality of life for the child and for the family, because dealing with a mental disorder, regardless of age, class, status, is challenging. And so once there's treatment, there's hope for the individual. Across board, the quality of life improves for the whole family. And then the child is also able to catch up, because they may have stalled in their academics, it may have been declining, and they may not have been able to make relationships, friends. Developmentally, they are able to catch up. And so this is one big benefit. It can also reduce self-harm and suicidality. We do know that some children and some adolescents, when they're having a severe mental disorder, can have some thoughts of self-harm or suicide. And so we reduce the risk when we treat. And then it reduces the burden on the primary caregiver, because you are now, once the child is functional, they are going to school, they are doing what they need to do, they don't need to be supervised all the time, then you can also function, you can get rest, you can go to work, you can do the things that you were initially meant to do. And so these are the things that you need to weigh, the risk you need to consider and benefits to weigh against each other, so we know if medication is the right fit for the child. And so this slide shows some of the psychotherapies that are available for children and adolescents with mental disorders. I'll not go into detail, but the idea of sharing the slides show that there are a number of therapies that are available to not just the child, but also for parents to be able to manage some of the conditions or the disorders they are seeing in their child. And so um, one therapy may not fit for one child, and so they may need to try something else that may fit for them. And so psychotherapies are not necessarily second line. They are meant to be together, done together with the medication so that they can work synergistically. And so, as usual, monitoring is always key. And so we have different monitoring parameters for all the medications that we prescribe. And so this is why you'll be asked to do certain lab tests. We may check certain things at initial visits, subsequent visits. There's a reason why we do follow-up reviews. We try to screen for if there are any side effects that may be cropping up. These are the reasons why. And then obviously, if we find that these we can stave off adverse reactions early if we see them early. So, um, back to some of the risk, the myths about medications. A big one is the addiction or dependence on the medications, and so um, parents sometimes are worried that their child will become dependent on it. So it's our job to try to dispel some of these myths and try to communicate and educate parents and caregivers that um, no, there's no addiction to the medication, but sometimes we can develop what we call tolerance. And so sometimes we may need to increase the medication or then stop the medication completely. And there's certain ways that we stop um, medications, and we usually discuss that at the beginning of the initiation of the medication. Then some people also believe that it can change the child's personality. So the way they were before they started taking medication, they were a certain way. When they started taking it, they've now become different to how you knew them. No medication can change a child's personality. The idea is for the treatment to reveal your child's true personality and not to suppress it. Um, and we find that parents sometimes report that the child actually comes into themselves. They become more confident. They become who they really were meant to be because they've received treatment and are no longer struggling with the symptoms of the mental disorder. Um, what if medication doesn't work? What do we do? We trial medications, usually for about 4 to 8 weeks. So you may find that initially, some people respond better to certain types of medication, and that's why we have a number of them. So if your child responds well to the first one that was prescribed, that's all well and good. But for someone, they may need a second medication or a third medication before they actually respond well, because we know that everyone's genetic makeup is different. We are moving to the point where we have something called precision pharmacotherapy, where your genetic makeup will be assessed, and we can determine which specific medication would work for you. Unfortunately, we are not there yet, but that is where we hope to get to. So while we wait to get to that point, we will have to trial some medications to see if what works for your child. Sometimes, so that's why I'm saying we may not always see that the first choice would work. And so that's why we always have to discuss with parents and let them know that this may work. It may also not work, so that when you come back in 4 to 8 weeks and we want to change, it's not a surprise and they may be expecting it. And that's when we actually need them to be able to monitor, and for us at home, to see if there's any changes, if there's improvement, so that we know if the medication is working. Um, some people also don't believe in medication because of their religion, and sometimes their religion does not support medication for mental disorder because it's believed that the disorder is primarily caused by witchcraft or a spiritual attack. But your role here is to present the options that are available, what can be done, um, and then explore if there are any alternatives. For some severe mental health conditions, medication has to be included in the treatment plan. In that case, we'll have to try to psychoeducate family to try to understand that medication is critical, and try to bring them to the point where they accept it. However, we cannot impose the medication on them, and we can only try to
About
explain and support them. Okay, so we should be done shortly. So This is the multidisciplinary team that should be involved in every child that has a mental disorder, and because they all play different roles in the child's treatment. And so sometimes you may have some coming in, some going out, some this, but this is the full complement. And you find at the end that yes, parents and caregivers are part of the team, because and they're actually central, because we can prescribe 1,000 medications, but if parents are not on board, caregivers are not on board, it may be very difficult um to treat the child. I'll just give an example where a parent was prescribed, a child was prescribed medication for epilepsy. That's a seizure disorder, and father was the one administering the medication. He was dividing the medication into two and not giving her the full tablet and putting it in banku to give to the child. And so this child was still having seizures. It was not resolving, and we didn't really understand why. And when we sat down and we explored, that is how we found out that this was what father was doing, and he thought that the tablet was too big, and so he decided that since it's big, let me just divide it and give her half so that she takes the half, and that was it. So we need to always remember that parents need to be at the center, try to explain to them what needs to be done. For adolescents, they also need to be um, involved as well, because if they are not on board, it can also be very difficult to achieve any therapeutic effect. So, in conclusion, we know that medications are a valuable tool, especially when they are evidence based and they are clinically indicated. They are not a shortcut or a substitute for comprehensive treatment. They are just one tool in your toolbox for managing mental disorders in children. Um, Child and adolescent psychiatry or mental health has a robust evidence base. Um, Prescribing within this population is always and should be always evidence driven. The risk benefits analysis must include the risk of not treating. There's also risk of not treating the child, because untreated childhood mental illness carries a significant long-term consequences. Shared decision making is always the clinical standard with both the young person and with their families. Safety monitoring is standard and should be a continuous responsibility. The prescription is the beginning of the work and not the end. And so every member of the team, including the parents, plays an irreplaceable role. And there's no single intervention, either professional or prescription, that is sufficient on its own. And so we must all work together for the benefit of the child. Thank you very much. These are my references. So
Thank you so much, Dr. Harding. That was a really great and informative presentation. Thank you so much. I think you've helped us to appreciate that medication is only one component of the comprehensive mental health care, of course, and that treatment decisions should always be in tandem with what guided professionals or qualified professionals, and of course, there should be an individualized plan for each person. At this point, I think we'll delve into the Q&A session, but I want to set the ball rolling. You mentioned that, okay, so usually parents are skeptical when they have to go the medication route. And I know that you equally mentioned that medication should go along with some interventions. I think my question then is, would it be possible for us to estimate or say, oh, maybe this individual or this person on medication will need medication for about a year, about 2 years? Because most parents ask that question or they want to be sure. So how long would it take before they are off the medication?
okay, thank you very much, Sanita, for your question. So yes, that's a great question that we get asked a lot in the clinic. And the answer is there are guidelines that suggest how long a person or an individual should be on medication, be it the SSRI for depression or anxiety, the stimulant medication for ADHD. But these are guidelines. They guide us. They are not um, fixed. And so every patient, every child, every adolescent is different. How they respond to the medication, the doses at which they are going to be prescribed, the side effects they may be having. So these are all things that would alter the time frame within which they will be taking the medications. I sometimes tell patients, yes, for something like antidepressants, we are looking at 6 to 9 months, usually 12 months of medication, but that is after symptom resolution. That's when we start counting. And again, I cannot give you a fixed date that is going to be on 31st December and we are going to stop, because it will be based on how the child responds. Should I start stopping and the symptoms recur, it means that then we need to go back to previous doses and continue treating for longer. So the simplest answer to your question is that yes, there are guidelines that suggest the time frames within which a child should be on the medication, but these are guidelines alone, and every case or every child is different, and so there are no specific dates that can be given for each child.
Right. Okay. Thank you so much. Please, we're still encouraging. If you have any questions, please, you can put them in the chat box, or of course, you can put up your hand virtually, that is. I think there's a question here. It says, is it possible for a child to relapse even if the child is on medication?
Okay, so yes, it's possible for a child to not necessarily relapse, means they recovered and they've had symptom resurgence again. So it means they didn't recover in the first place. But yes, a child on medication can still have symptoms, and symptoms can worsen. It may mean that a number of things, either the medication is not enough, the medication is not even being administered the correct way. Maybe they've hit puberty, and so they may need a higher dose of medication because they are metabolizing medications faster. Hormones have come into play. There are different other environmental factors that have come to play that are affecting the symptom presentation. So there are a number of things that can worsen symptoms even though the child is on medication, and so that is why monitoring and reassessment is always critical. So we do follow-up review so that we can see if we need to add on something else, take off, institute other interventions to try and manage worsening symptoms.
Okay. All right. There's another one here. It says, how can parents support their child on medications? And then it follows on to ask, what about adolescents? How much say should they have? That is.
Okay, so I'll try to answer the first one. Um, Parents support their children on medications. Can support their children and that any child that's on the medication by one, either they administer it directly, especially if it's a young child. If we are looking at 7, 8, 9, they'll need some assistance with the medication itself. They can also set reminders, make sure that they've eaten well, make sure that they're also getting good sleep, they are following their psychotherapy interventions or OT or speech therapy to help make sure that they are not only focusing on the medication, but other interventions that have been put in place. For adolescents, it becomes a little bit more tricky because we need them on board. They are not fully adults yet, so they need we need consent from from parents to administer medication, but they also cannot consent on their own. But they do something called assent. So they we need them to come on board to agree. If they don't assent or agree to take the medication, there's not much you are essentially stuck, because you they are not children that you can say, hey, you need to take this medication. But we need to bring them on board. It's the reason why right from the get-go you involve them, you let them know that this is the reason why you are taking medication, these things you are experiencing. They need to be on board and be at the same pace. So it's not, I find that some parents want to hide what is going on, or hide why the child is taking medication, hide it in food, in milk, in juice, and all of that. That is not that will not work with adolescents. They need to be in the know. They need to be aware. So although they have a say, they do not have the final say, but it can be very difficult if they are not on board with medication.
Okay. So, Doc, there's another one here. It says, at what age does a parent have to let the child know what medication they are on? And then, as a follow-up to it, um, they're asking, especially if it's a stimulant medication, which apparently some people abuse these days. At what
So
point? Yeah.
yes, so for medication, as early as the child is able to understand what they are taking, so they ask questions. They are very curious. Oh, why am I taking this medication? Even multivitamin, they're asking you why they are taking it. What is it for? Why other people are not taking it? So as long as your child can understand, can ask those questions and can understand, I think that's the point where you need to let them know that this is the medication you are taking and this is the reason why. um as to abuse of stimulant medications, yes, we know that some people can abuse it, and it's the reason why this is where parents would come in with support. So we need them to be monitoring how many of the medications, how much was taken, at what time, are they stockpiling medication to go and give to friends to abuse it or something like that. So parents would come in here with with their support.
All right. Now, this question is quite interesting. So, this individual is asking, would you recommend herbal medicine since it has proven to be effective and has stood the test of time?
So I cannot recommend herbal medicine because I'm not a herbalist. I am a psychiatrist who was trained in orthodox medicine, and so I have evidence for orthodox medicine. There have been studies that have been done on the safety and efficacy of these orthodox medicines in this special group, so in children and adolescents. And so it's the reason why I would, that's the medication group I can stand on. But as to herbal medicine, I cannot advise that. And I can also not advise combination with orthodox medicine, because I don't know what is in herbal medicine. And so I don't know if there are any interactions with orthodox medicine. So I will not be able to recommend that.
All right. Another question here, can the child be allowed to take a medication holiday, say the weekends?
This is something that's done for a stimulant medication for attention deficit hyperactivity disorder. So yes, we know that we can have something we call drug holidays, or medication holidays. However, I find that doing it may be better to do it over a longer period. So maybe vacation, holidays, longer. But weekend, children are still going to do homework. They still need to be organized and focused. steady for the coming week. And so I find that weekends may be too short. It's just 2 days, and then they don't take medication. Monday, they come back. So if you have a longer period where you say 2 weeks, 3 weeks, you don't want them on medication, that's easier and more understandable for them. And it's more consistent. So for the child to understand that, okay, so during the school period, I take medication because I need to focus, I need to be able to pay attention in class. But during holidays, I have a break because I'm not required to sit in the classroom for long periods of time.
All right, and one more question here. This parent is asking, so for a child with autism who is not on any medication, what kind of monitoring is needed? And who or where should parents or caregivers report monitoring to see if they need changes?
So a child who has autism and may still and is not on medication may still be undergoing therapy. It's still treatment. So speech therapy, ABA, or that's applied behavior analysis, occupational therapy, behavior therapy. They may be undergoing all these forms of treatment and still require monitoring with the primary um, um, practitioner who diagnosed autism and prescribed all those treatments. And so they'll need to continue monitoring to see if all these therapies that have been instituted are actually working, or we need to institute different things or focus on different aspects of the therapy. So yes, although it's not medication, it still requires monitoring.
All right, Doc. Thank you so much. So I think some key takeaways from our conversation today. But before I do that, please, do we have any more questions? I don't see any more questions in the chat box. I haven't seen any hand up, so I take it that all is well. All right. So just some key takeaways again. So mental health conditions, of course, in children, they are real and certainly treatable. Medication is not always the first or only option. Treatment works best when combined with, of course, the support from family, therapy as well, school collaboration, and of course, professional guidance. So we kindly ask that you seek information from qualified mental health professionals before making any treatment decisions. So on behalf of the entire team, okay, then I missed it. Sorry. Okay, I understand a hand is up. There's another question. Okay, I see one question here. That's from Martha. She's asking, can you recommend a medication for students or for a student who is aggressive and does not respond to behavior therapy?
Hmm. So yes, there are medications available, like I said, for challenging behavior. But it would have to be on a case by case basis because um we need to assess if the child does really need that medication, and then also if that medication would be a good fit for the child. Before we prescribe the medication, assess, monitor, see if what the medication we want to prescribe um, to try to reduce any side effects in that particular child. So yes, there are medications available for aggression in children with autism, especially when they don't respond to behavior therapy. But these are short-term medications and not something that the child should be on for long term, and because of its side effects. Yeah.
All right. Thank you. I understand there was a hand that was up. I'm not sure. I think the name
Yeah,
was
it was me. The
okay. All right.
last answer, yeah, last answer I gave had satisfied my question, so then there's no need to
Okay. All right.
ask the question again. Thank you.
Thank you too. All right. So again, on behalf of the entire team, We just want to extend our sincere appreciation to, of course, you, Dr. Harding, for making the time to share your expertise with us today. And to everyone who was on with us on call today, we say thank you so much again for taking the time. We'll be doing this from time to time. We're hoping that more of us will continue to patronize. And we have a community. I actually have placed, or we have the link in the chat box. So different topics. We have a platform for parents, equally one on neurodiversity and EdTech Fair. There's one on mental health awareness, corporate wellness as well. And then we have a resource library where we share educational content or materials from time to time. So please feel free to click on the link to join any of these platforms. And on that note, we want to say a big thank you again. Do enjoy your evening and see you another time.